Welcome to the Center Collaborative, Creative Solutions in Behavioral Health and Criminal Justice, brought to you by the Oregon Center on Behavioral Health and Justice Integration, which is also known as the Center. We at the Center are all about solutions. Our job in Oregon is to facilitate improvement of the system so behavioral health and criminal justice can work better together to engage people in treatment while promoting public safety. I am your host, Chris Thomas. I hold a master's degree in clinical psychology and have focused on the intersection between behavioral health and criminal justice for 20 years. Over 7 of those years were behind the walls of a maximum security prison. During this podcast, you will have the opportunity to sit in on real, in-depth conversations with experts about complex topics in a way that is both fascinating and digestible. We will focus not just on what is wrong with the system, but what is going right and how we can work together to evolve. This podcast is a conversation in a series of conversations where we touch on people's legal rights and their options related to seeking medical care. Since our conversations are intended for informational and educational purposes only, they are not a substitute for or a reason to delay seeking professional legal or medical advice. In this episode, I am joined by Michelle Brandsma, Greater Oregon Behavioral Health, Substance Use Disorder, and Trauma-Informed Care Manager, to talk about the naloxone distribution program and how it saves lives by reversing narcotic overdoses, reducing the stigma of addiction, medication-assisted treatment as a medical intervention supporting the therapeutic intervention, using peers to enhance engagement, build hope, and meet people where they are, and the need for holistic treatment. I learned so much during my conversation with Michelle. I think you will too. Welcome to our conversation. I am thrilled to have you on the podcast today, Michelle. Thank you so much for joining me.
Thank you. Thank you for having me.
So starting off, let's talk about what the Substance Use Disorder and Trauma-Informed Care Manager does at GOBI.
It's an eclectic position. We work with the 12 counties of Eastern Oregon CCO, and we provide technical assistance. We help with grant writing. We provide trainings. My team also manages a couple of grants. One is called the SOAR grant, and it is for opioids and stimulant disorders, and it's a housing grant. And what that grant does is we provide financial support for rental assistance, for motel rooms, any of the barriers that may come up around someone's ability to get safe and stable housing. And so we work alongside with the providers in Eastern Oregon in order to get individuals either into their own housing. Many of them are going into motel rooms because that's all that's available, or getting rid of some of those barriers like past electric bills or some fees that they may have associated with previous housing that they're not able to pay, and even getting the application fees for them. So it covers a wide range of services that we're able to cover for that funding to help them get into some stable housing. We work to initiate access by helping to increase the service array for substance use. We work with programs, for instance, that may be starting up medically assisted treatment programs, and we help to get that going. And another piece that we do is through receiving grants, been able to provide naloxone throughout not only Eastern Oregon, but throughout the state. And some of that naloxone that we've distributed, this is the 3rd year of our distribution of naloxone. And we've been able to provide it to, obviously, the programs, but we also provide it to any organization who's working or has requested being able to provide naloxone to their community members or to anyone who they're serving.
I'm wondering, not everybody may be familiar with naloxone and what that does. So could you talk about that a little bit?
Sure. So naloxone is actually a blocker. And what it does is, to put it in simple language, it blocks the effects of the opioid. so that when someone is in distress or in an overdose situation, they can be given naloxone, and then that will reverse the overdose. And the nice thing about naloxone is that if someone is not in an overdose, it's not going to have an effect on them. So that hopefully takes away that fear of that, oh, they're putting this other drug out into the community. Because someone who, like myself, I'm not using any opioids, I do a naloxone nasal spray, it's not going to affect me. So I think that's probably the easiest way to describe naloxone, is that it reverses the overdose.
So it saves lives if
It
it's given to
saves
someone.
lives.
And now there is, like you were talking about, the nasal application for it versus it used to be intravenous or intramuscular, but
Right.
now it can be given nasally.
Just a nasal squirt.
So it's
Yes.
really easy to give someone. It can save their life. It won't hurt them, but it has saved a lot of lives in Oregon, folks who maybe would not have made it if they hadn't been given that measure.
Exactly. And part of that with that naloxone is law enforcement are carrying it. Even our CEO carries it around with her. So a lot of people are just starting to carry what we call a kit, which a kit contains 2 doses of naloxone. It also has the instructions on how to provide that to the individual that's in distress. And it's got a 2-year window before it will expire. So it lasts for quite a while. But along with the naloxone, what we also have been doing is we've been putting out what's called a nalox box. And what that is a metal box that we've supplied to our providers or to anyone in the community who has asked for them. It's a metal box. It's about 6 inches by 4 inches, and it holds 2 kits of naloxone. And what people are doing, so 4 doses of naloxone. And what the programs that we work with are doing is they're taking those and they're putting them in areas that are known as high risk use areas.
You talk about meeting people where they are.
Yeah,
Yeah.
exactly. So if the gas station on the corner in their bathroom is somewhere, then what the providers are doing is they're going and they're talking to them about, can we put a nalox box up here?
Mm-hmm.
And so I do have one story from Malheur County that just came to me just the other day of an individual who was in overdose. Their peer got the dose out of the nalox box and reversed the overdose. And then that started their journey of recovery.
Yeah.
And so it is a matter of meeting the people where they're at, because they're not going to go and knock on the door and ask for a naloxone dose.
No,
So
especially law enforcement may be carrying it, parole and probation may be carrying it, but the probability that someone is going to go to an authority figure to ask for it is much lower than if it was somewhere where people are known to use. They're much more likely to save someone's life using it, because going to the authorities is pretty scary in that instance.
exactly. And it's important to mention too that naloxone not only reverses for heroin or the opioids, it also reverses for the fentanyl. So it's important to know that, especially with the way that fentanyl has such a higher rate or probability of overdose, because it takes such a minimal amount of the fentanyl to have that effect of overdose. Part of that naloxone piece is that I want to say about a year ago, maybe 6 months ago, we've realized that the corrections officers throughout Oregon and parole and probation officers, it was brought to our attention that they were struggling to get the naloxone.
Mm-hmm.
And we had about 500 cases. I believe it was a little over 500 cases that it was funny. I put out an email one day, and by the end of the next day, I had provided them with over 500 cases of naloxone. And that wasn't specific to Eastern Oregon. That was throughout Oregon. That was a pretty big endeavor for our team. It was during COVID.
Yeah.
You have to give a shout out to our office manager, because at the time she was a one-man show in our main office, and she put those all together for us and got them shipped out.
We
And
were really excited that we were able to help bridge that conversation as the center with the work that was happening in Gobi, and then be able to bridge with statewide PMP in order to help to get those boxes out. And what a gratifying project to be able to help out with bridging.
yeah, it was really heart filling.
Mhm.
It was one of those, so this is why I do this work kind of situations was, and it what it's done is it's taken away some of those us and them attitudes that
Mhm.
oftentimes in our, especially when it comes to substance use, that you deal with. And it's really brought forth a, we're all in this for the same reason. And if I can help you, then by all means, let's help each other.
Mhm.
Let's do what we can to make sure that people are not dying.
Yeah. And for PMP, parole probation, going out on home visits or other
Mhm.
places, they could have clients who are overdosing that they could save. There's also the possibility, if they're needing to do a search, that they could come in contact with, for instance, fentanyl, and could overdose themselves. And so it could also save the life of a parole and probation officer who accidentally ingests the drug without meaning to.
There have been officers who have had to have the naloxone used on them because of that very situation. And then they're in that overdose distress situation just as much as the individuals that they're attempting to help.
Mhm. Because fentanyl, please help me understand this. I think that I've heard that fentanyl doesn't look the same all the time. So it can look really different. It can be in pills, or it can be in powder, or it can be hidden. So you wouldn't necessarily look at something and think, oh, that's fentanyl.
And the thing about fentanyl too is that when it is in a powder form, it looks just like heroin. It's
Mm.
white.
Hmm.
It's a white powder. So it looks like heroin. And so that's what's happening oftentimes with it, is that it's being mixed with the heroin.
Mm.
And the individual who's buying what they think is heroin
Hmm.
is actually buying heroin mixed with fentanyl.
Mm.
And originally, when it started hitting the streets, and I believe this to be true, maybe wrong on this, is it was in a pill form.
Mm.
And so it was pretty distinctive that this is fentanyl. And now it's moved into that where it's in that powdered form as well. And people are ingesting it without knowing it. It's like any other drug, it manifests into what is familiar looking to the population. So people of all ages, adolescents, young adults, older adults, are ending up thinking they're taking one drug and they actually end up taking fentanyl, and they're overdosing. And many are dying from the
Yeah.
overdose. So the naloxone distribution program helps to break some of that cycle, hopefully.
So, is fentanyl found in other drugs besides heroin or morphine and the opiates? I mean, do you ever see it mixed with anything else like methamphetamine, where someone really has no idea that they're getting fentanyl, or they think they're getting methamphetamine and they end up with fentanyl? Are we seeing that happen as well in the streets?
So I haven't heard about it personally. So I don't know that I can speak on that personally, that it is being mixed with the stimulant. Years ago it was, you mixed a stimulant with an opiate and it was called a speedball.
Hmm.
I'm sure that practice is still going on. And that being the case, I'm fairly certain I could say yes, that
Hmm.
stimulants are also being mixed with it. Years ago, there was also a time when, before fentanyl hit the streets, and that back in the 90s, the people who were selling the methamphetamines was cutting it with heroin.
Hmm.
Because at that time, the methamphetamine didn't have as strong of a physical addiction as it has now. It was
Interesting.
made different than it is now.
Uh huh.
And so what they did, because the heroin does have that physical addiction, they were cutting it with the heroin so that it would cause that higher intense level of addiction and that desire to have it, the cravings
Oh,
for it
wow.
even
So they were
more.
ensuring their customer base basically by,
Yeah, yeah,
wow.
exactly. So it's interesting when you think about the way that the consuming of the illicit drugs constantly evolves.
Mm.
Just about the time you think, oh, yeah, we're done with that, or that's new, then that's an old process now. And now we've moved on to another type
Mhm.
process.
Mhm.
So the reversal of the overdose is part of the prevention. How do you prevent someone from dying? Well, you put the tools out there that are necessary that hopefully will be used, that they can survive it. I'm certainly not a proponent for using, but I'm a realist too, that I know that substance use is going to be here. One of the things that tends to happen when we start having these epidemics, like for instance, the heroin, then we tend to forget to talk about the other drugs that are
Mhm.
still alive. And we have the methamphetamine, which is since 2009, the increase in deaths from methamphetamine is over 400%.
And we
You
don't really talk
know,
about that. Most of
we
the
don't
time, the
talk
national
about that.
conversation is about
Right.
opioids, but not about methamphetamine, and especially that you can overdose from methamphetamine and it can kill you. And you don't really hear about that.
No, we're not hearing about it the way that we did. The stimulant use can cause nerve damage, it can cause brain damage, it can cause heart attacks, it can cause the abscesses because if they're using a needle to take their drugs. And so, yeah, we don't talk about stimulants as much as I believe we need to.
Mhm.
Methamphetamines. And I do know that in Eastern Oregon, methamphetamines is still one of the main consumed drugs.
Mhm.
And I'm not saying that, oh, we should talk about opiates less.
Mhm.
I'm just saying that when we are talking about opiates or illicit drugs, we should be identifying the effects of all of them that's happening to the community.
Right.
And how can we address it, which I try to do in the work I do, is I try to address it in a holistic manner. The using results for an individual, the using experience, if you will, is different. If I use an opiate, I'm probably going to start nodding out, maybe throwing up, getting sick. I'm going to be maybe lethargic. For
Mhm.
stimulants, I'm going to be rather busy. I'm not going to sleep. I'm not going to eat. I'm going to become hyper focused on things. So the reaction to the drug is different, but the addiction to the drug is still real.
Right.
And the outcome is still, to use an old fashioned term,
Mhm.
it's still the people, places, and things are going to be affected in negative ways by my use, besides just myself.
Mhm.
And people are going to die. People die from alcoholism in alcohol related accidents, and oftentimes they're not identified that this was an alcohol related death
Mhm.
because it happened in a motor vehicle.
It seems to me sometimes what is missing in these conversations when we talk about drug addiction or alcoholism is that no one starts drinking or using methamphetamine or using heroin thinking, I'm going to use this and I'm going to get addicted. And that's my goal, right? There are a lot of reasons why folks use substances that are completely understandable given the situation that folks are in and the things that they are dealing with. But I think in our country, we have such a tendency to vilify folks who are using it. We look at the far end of the continuum of what has happened through all the use and all the terrible things that have happened to that person and to their lives. But we forget that there's a reason that someone started using it, and that's the thing that when we're talking about treatment, that we need to make sure that we're still addressing, or it would be very difficult to stop using. It's a coping mechanism. It's not a great coping mechanism, but it's a coping mechanism nonetheless.
Exactly. So to go off of that, of course, I've been a substance use clinician now for a little over 20 years. I'm also in recovery a little
Mhm.
over 20 years, 22 years. And one of the things when I used to do some trainings with the staff that I supervised at the time was I would bring up the fact that don't tell the client a lie. Don't tell them they can never use again, because that's not true. They can use again. They may not like the consequences, but they can use again.
Mhm.
And then another thing on that piece of why do people start using, I think that's such a huge piece that oftentimes gets overlooked.
Mm-hmm.
Oftentimes people start using not because I feel bad or because I don't like my life or because I'm so uncomfortable or my life is miserable. They start using because, you know what? All the cool kids are standing behind in the gym and under the bleachers and they're all smoking pot and they're all having fun. And I'm out here by myself. I want to be a part of. I want to have that feeling of having fun and being valued, of being important,
Mm-hmm.
being visible. I remember a client told me one time, I started using because I always felt like I was never seen.
Mm.
And then when I started using, what happened for me was I started coming out of this shell and I started being able to talk to people and be a part of the parties and being asked to do things with people. And then this is an important piece of this, though. Then it changed.
Mm.
People quit asking me to come around. People quit asking me to be a part of. People didn't want me to be involved in their family gatherings or this or that. And that was that crossing of where I was considered a social user
Mm-hmm.
to where I was considered an addict.
Mm.
And what he said was, and I didn't plan on either one. And I thought, and that's so true. We don't
Yes.
plan to become full-fledged addicts. We don't plan to become even perhaps social users. Our mindset at the time that we start using is generally, I just want to be a part of.
Mm-hmm.
How many times have we said about a teenager, especially, oh, they're 16. What do you expect?
Mm-hmm.
Right?
Mm-hmm.
When they're acting out.
Mm-hmm.
And then stop and ask yourself, how many times have I said that about a 16-year-old that's getting straight A's and going on and in no trouble, right?
Right.
But we say it about that 16-year-old that's acting out because that's also part of our coping skills.
Mm.
Is if I can normalize this behavior for my child,
Mm-hmm.
then my child is just doing what other kids do and it's quote unquote normal.
Mm-hmm.
And so sometimes, and this isn't a discredit for parents or any of that, sometimes we as adults miss the mark and we send the wrong message.
Mm-hmm.
We send that message of, oh, yeah, I don't really want you to do it, but you're just doing it because it's normal. Mm-hmm. So what if we stop normalizing social use? Which is hard to do because a lot of adults are not addicts and not alcoholics, and they do social use.
Mm-hmm.
Socially use.
Oh, absolutely.
They
yeah.
socially use their alcohol or cannabis or whatever it is, and it doesn't have that negative impact on their lives, right? Mm-hmm. Until it does.
But the catch-22 is, but it doesn't necessarily mean that it will. And yeah, you just don't know. You don't know. But I think it's important to keep that in mind when we're talking about addiction, particularly when we're talking about addiction with methamphetamine or heroin, is a lot of people use substances one way or the other. May that be alcohol, nicotine, all the marijuana, all the ones that are considered socially acceptable. And some folks will become addicts and some folks won't. But nobody starts off thinking, boy, I'm going to become an addict. And so to have that compassion for folks that are using substances that we don't, that collectively as a society, maybe we don't totally agree with, heroin or methamphetamine, but to have that compassion around it, that nobody starts off thinking, this is my plan, I'm going to be an addict by 30. But having that compassion, and I think sometimes it gets lost. And then when we're talking about treatment, sometimes it gets lost that there were reasons that folks used, and just expecting someone to stop without dealing with and talking about the reasons and planning for the reasons, I would imagine would make it really hard to stop using without that piece of it.
And I think that's another piece of it too, is when someone is coming into treatment, you have to be realistic about it.
Yeah.
Telling someone when they first get into treatment, oh, your life is going to be so much better, that implies that starting today, your life is going to be better.
Yeah.
But the truth is that early treatment is really difficult. Early recovery is extremely difficult because the coping skill I've used to work through whatever my issues have been for so
Mm-hmm.
long, now you're telling me is either going to kill me or
Mm-hmm.
I have to get rid of it. And not only has this coping skill worked for me, but it's also been my best friend because all the other doors have been shut.
Yeah.
See?
Yeah.
So there's this moment where the walls start coming in. And as a person in recovery, one of the things that I say when people say, how have you gotten so many years of recovery? Well, besides one day at a time,
Mm-hmm.
I remember those first 24 hours and I don't ever want to feel like that again.
I can.
Because those were the excruciating time, that first few hours, those first few days of recovery. And it's a moment of, oh my gosh. And that's why so many people have difficulty maintaining in recovery, especially early recovery, is because the pain gets too much.
Mm-hmm.
And so having a good, strong therapeutic intervention, having someone who can do outreach with you, I think Oregon is moving in the correct way
Mm-hmm.
with having the peer support working with them, making sure that even if that individual that as a clinician I'm working with doesn't want to come and see me, maybe they'll come and see that peer.
Mm-hmm.
Maybe they'll allow them to bring them a cup of coffee.
Mm-hmm.
Maybe just having a conversation, building that relationship. And when you are in providing therapeutic services, that's where it starts. Building rapport, building that relationship. And it doesn't matter what the drug is.
Yep.
It doesn't matter what the drug is. I've often heard alcohol separated out from meth. And I remember years ago, I was at a training and the trainer was saying a drug is a drug.
Mm-hmm.
And we need to get to that point. We
Mm-hmm.
need to get to where when legislation or laws or drugs are being identified as a pandemic, we need to get to, I believe this, I should say, clarify that. We need to get to a point where we're talking about drugs,
Mm-hmm.
not a drug,
Hmm.
but drugs are the epidemic.
Mm-hmm.
The results of severe drug use is the epidemic.
Mm-hmm.
How
Mm-hmm.
do we stop that?
Mm-hmm.
There was just two very large busts in Central Oregon, and they both included methamphetamines
Mm-hmm.
and heroin, opioids, and fentanyl.
Mm-hmm.
So it's alive and well. Methamphetamines is right up there with the opioids. And it's just a matter of let's start talking about it in that fashion. Let's just
Mm-hmm.
start talking about it in drugs.
It makes me wonder, and this could be a rabbit hole. So I'm just curious. This is part of the you and I and water and talking, and I'm just curious because I'm a curious being. It makes me think, though, the substances, whatever they may be, are the symptom of the epidemic. So don't get me wrong, opioids and methamphetamine and alcohol can cause really serious damage to folks. But there's lots of things that folks do that is damaging to their health and to their safety. But it makes me wonder what the underlying epidemic is that folks are using the substances to cope with. What is that epidemic in the United States that's underneath the substance use that's being masked about the substance use? But we talk about the substance use like the drugs are the problem. I'm not saying we should ham them out to everybody. They're obviously problematic, but what is underneath all that substance use that's driving the epidemic, that's driving the want or need to use?
So I think there's several things. As you were asking that question, I think what came to my mind most of all was we live in a pretty trauma induced country. We don't generally, the last 10 years, trauma has been a main focus, and it's come to be realized that trauma has such a huge role in the substance use that occurs.
Mm-hmm.
But we really do, when you think about it, school shootings, you think about women and the attacks on women, you think about the interracial issues that occur, you think about the inequity. And this is just, again, my opinion.
Mm-hmm.
But my opinion on it is that the substance use makes or gives the illusion of I have some control
Mm.
because I'm the one who's going out using whatever the substance is. So I have some control. The financial piece of selling drugs, the money that can be made. So viewing that in a short range of I have the opportunity to make a lot of money here.
Mm-hmm.
And then again, it's masking or I don't have to look at or work through or discuss my emotional state.
Mm-hmm.
So I think for oftentimes it's that masking effect that drugs do.
Mm-hmm.
My world isn't quite so dark if I can at least be enjoying it through this.
Mm-hmm.
And that's just my opinion on it. Somebody else might say, yeah, she's way off base. And I'm cool with that too. But I can tell you, as someone in recovery, there comes a point where there's not really any excuses for the using anymore.
Mm-hmm.
It's if you want me to get out of bed and be a functioning human being, I need to do this
Mm-hmm.
because I no longer can get out of bed without having a hit.
Mm-hmm.
I can no longer deal with my children and the responsibility of my children without being high because I can't get out of bed.
Yeah.
And that's being said as a woman who has children and who is recovering from methamphetamines.
Mm-hmm.
There came a point in my own particular world where if I didn't have something to wake up in the morning with, I wasn't going to wake up for 3 or 4 days.
Oh,
And I couldn't do that.
yeah.
I couldn't not wake up for 3 or 4 days. So
Yeah.
there's, again, it's you don't know when the line gets crossed
Mm-hmm.
and then the line becomes normalized.
Hmm.
Because this is just how my life is. So when you're looking at the progression of the methamphetamine use or cocaine or heroin or alcohol or whatever it is that you've crossed that into that addictive state,
Mm-hmm.
now this is my new normal.
Mm-hmm.
And not oftentimes, but I know the perception I had, and I can only give you that, is when people started to try to intervene
Mm-hmm.
on what my life was, they became the problem. And that happens in treatment.
Mm-hmm.
You're trying to stop me from doing something I not only, maybe I don't enjoy it anymore, but it's something I have to do.
Mm-hmm.
It's
Mm-hmm.
something I have to do because I can't imagine my life with it, and I can't imagine my life without it.
Yeah.
And so being able to have someone that can come into your life and be able to say, you know what, maybe today's not the day. Let's just hang out, see what happens. And here's some coffee. Here's something to at least help that someone in this world finds value in you.
Yes.
Because I think that for many, by the time that they reach that late stage piece of it, nobody finds value in me. How could they?
Yeah.
I'm a liar, a cheat, and a thief.
Yeah.
Nobody wants me in their home, around their children, around their dog.
Yeah.
The only people that want to come and see me regularly are the police officer, the parole and probation officer, or somebody who wants to complain to me about the way my kids are being taken care of.
Yeah.
So all of my messaging that's being given to me by the time I'm sitting across that desk with that counselor in treatment, that's all that baggage I've brought in with me.
Mm-hmm.
And a good clinician, and we have lots of good clinicians in Oregon,
Mm-hmm.
have the ability to sit across that desk and say, okay, let's look at this one page at a time. We're not going to read your whole book, but let's look at one page at a time and let's see what's true and what's not true.
Hmm.
Because we end up in recovery needing to find out what's true again.
Mm-hmm.
Because for so long we've lived in this what I like to call the mirror of illusion,
Mm-hmm.
which is my own created reality about how I perceive the world and how the world perceives me.
Mm-hmm. Mm-hmm.
And fortunately, there's a lot of people out there willing to sit down and say, let's look at your book one page at a time.
Mm-hmm. It seems like there has been advances in the last decade or so, last couple years, around more use with peers. So, folks that will reach out and meet someone where they are, but also can model, you can do this, I did this, there is a path through. And then also medication assisted treatment has been much more popular, and it was very controversial when it first started. I want to talk about MAT a little bit because I think in some places it still may be a little bit controversial. So I really want to talk about that. But I'm wondering about the advances we've made in the last couple of years, and if there's any others that I'm not thinking of or that you want to touch on either one of those.
I think those are the two big ones. I think that the peer support, the use of peers, the peers being certified now,
Mm-hmm.
it still reminds me anytime I think of the peer support, the certified recovery mentors are
Mm-hmm.
people who had lived experiences who are now working for organizations doing outreach as a peer recovery mentor. They're
Mm-hmm.
called CRMs.
Mm-hmm.
And it reminds me of the 12 step AA,
Mm-hmm.
Alcoholics Anonymous, was the first 12-step program developed in 1932 or 33.
Mm-hmm.
And what the 12-step community programs do is they connect you, you find a sponsor. What does a
Mm-hmm.
sponsor do? A sponsor takes your phone calls. They
Mm-hmm.
take you for coffee. They pick you up and take you to meetings. They listen to you. They allow you to speak your truth out of your reality. And then they challenge that
Mm-hmm.
on how good is that for your recovery.
Mm-hmm.
Does that
Mm-hmm.
any of that sound like what a peer mentor does? So it's taking that we've known since
Mm-hmm.
1933
Mm-hmm.
or before. Well, that's first meeting, 1933, and it's just brought it into the 21st century of, okay, so the work that this individual does is so relevant
Mm-hmm.
and such an integral part to recovery that now we're not only going to expect an individual to go to a 12-step meeting, get a sponsor, utilize that sponsor. We're going to develop a whole new concept with treatment that says we're going to do inreach and we're going to do outreach.
Mm-hmm.
We're going to go to those individuals that aren't perhaps done yet.
Mm-hmm.
We're going to go to the homeless camps. We're going to meet them where they're at and give them some support until they get ready to walk through the doors of that treatment program.
You are
Because
singing my song, Michelle, about going to folks where they are instead of expecting them to come to us on our timeline.
exactly, because the
Yes.
old model of treatment is you get set up for an assessment, you get set up for an intake, and it all happens in the office with the clinician from the minute you start. But when you think about how many people fall through the cracks because they're just not ready to start.
Yeah.
And that's where that gap, that CRM is able to get in there and fill in that gap. And the truth is they might not come into treatment,
Mm-hmm.
but at least they know when they are ready for treatment where to go.
Mm-hmm.
And they've got support getting there. And we're utilizing the CRMs throughout, not only through the substance use, but also through the corrections and through the emergency rooms. And so the expansion of utilizing a peer support of whatever it is that the individual may be suffering with, or that is huge in changing. That's a huge piece of changing how treatment is provided.
Yeah.
And how treatment is accessed and how it's accepted. I've been a sponsor, I've been a sponsee, and I'm thinking, wow, my sponsor could have made a lot of money off of me if she would have been a certified, because I spent a lot of time with her.
Right. Being a certified peer versus a sponsor, I'm imagining there's also a lot of education that happens with that and training.
Yeah, they have to go through, I'm going to say 40 hours or 60 hours of training They've taken away where you have to be abstinent. So even the state has walked back the whole abstinence piece of, for instance, being a certified alcohol and drug counselor. You don't have to be abstinent. I don't know any of them that aren't, but there may be some that I'm not aware of. But yeah, it's, you go through training, you get certified through the state, through the Mental Health and Addictions Certification Board, MACBO.
Mm-hmm.
And the nice thing is, though, that prior to certification, you can start working in a program. So you can get registered with MACBO and start working in a program, and then you can work towards your certification. So it's not that you have to have that certification to walk in the door to be a peer mentor. So it's great. And then I also wanted to touch on the medically assisted treatment. And there are still some. It used to be too that you go to a 12-step meeting, and it wasn't unusual to hear that you weren't clean if you were on medically assisted treatment, MAT, if you were receiving MAT. And there was a lot of judgment about it. And unfortunately, people quit coming to the recovery meetings because of it, because you're not clean. Once you get off your MAT, then you'll be clean. And unfortunately, it was done not only with, say, the Suboxone or methadone or whatever MAT is working for that individual. It was also done with things like for ADHD medications and things like that. It was, no, you're not clean.
Oh, wow.
And I've heard stories of where people in the 12-step program have told their sponsees, you need to get off that medication, and it's for their ADHD or this or that because you're not clean.
So the thinking on that, Michelle, for our listeners, just in case you're not familiar with MAT, and please correct me if I'm not explaining this well, is that medication-assisted treatment, it is medication that assists with treatment. So you just can't give somebody a pill and then expect things to be better. But the drugs themselves, the short answer is that they really help with cravings. So you can get through that in order to be able to engage in treatment without all of the cravings. And then the piece with, did I get that right?
That, and they block like the opioid receptors and that. So yes, but yes, it's to help with that, to get through that, the emotional, the head stuff, the cravings, the effects of the withdrawal. Even. So for instance, if you're withdrawing from heroin, you're probably going to get what's called dope sick. You're going to be nauseated. You may have some discomfort in your bowels. You may throw up, sweating. It's not comfortable coming off of opioids.
No.
So what happens is that actually helps you to make it through that, because oftentimes, especially, and this is an important piece, I think, to talk about, is that dope sick occurs. So how do I get well by using more heroin?
Right.
Or more
Which
opioids.
within itself is completely illogical. It's logical, right?
So the medically assisted treatment helps me from needing to get well.
That makes sense. Yes.
It stops that for me. If I'm going to a 12-step program and they're saying I'm not clean, because what the unfortunate thing that with MAT is people don't understand it, right? If you've never done something, you don't understand what it does.
Yeah.
So they're making a judgment that you're trading one drug for another. And in reality, you're utilizing a medication.
Right.
And it needs to start being viewed as a medication. It's prescribed by a medical doctor.
Right.
It's supervised by either an NP, medical doctor, nurse. It's monitored. They're bringing it up or down to make sure that it's meeting the need and that it's effective, like any other type of medication. When you think of, for instance, blood pressure medication, the doctor may not know exactly the correct dose immediately. So you play with it to get it to where it's in that right area for you, where it's effective. And medically assisted treatment is just that.
Mm-hmm. Mm-hmm.
It's getting the right dose of the medication to where someone is able to, for instance, sit in a group and get the treatment they need.
Right.
And then they do the tapering off of it, just like you would for one of those other type of medications.
Mm-hmm.
So it really is changing how I think about MAT, and I start looking at it as a medical intervention because
Yes.
that's what it is. It's a medical intervention to help stabilize, to move through, to get to where I can be comfortable,
Mm-hmm.
and eventually to where I can taper off of the drug because I no longer need it.
Mm-hmm.
And
Mm-hmm.
that has to be an individual process. And the last thing someone needs when they're in their individual process is someone telling them, you're not clean because you're getting this medically assisted treatment.
Yeah, and let's just say I completely agree with you. But let's just say for argument's sake, someone is through their doctor has a substance and it's making it easier for them to not be on the substances that are ruining their lives. They're not using the substances that are ruining their lives and it's helping them move their life forward. So why are we being judgmental about that? I guess I'm a pragmatist. If someone is able to move forward and they're able to have a prescription in order to be able to function, lots of us take prescriptions for mental health reasons that allow us to work through our daily lives, whether that be something with MAT or whether that be Zoloft or Paxil or something else. So that is helping our brain chemistry and helping us get through our lives. It seems like it's seated in like a judgment around what is normal and what is acceptable for being normal and for being clean versus meeting people where they are so they can move on with their lives.
So I would take it even one step further. It is two completely different thought models,
Mm,
therapeutic models. You have
mm,
the abstinent model where you don't consume anything.
mm-hmm,
You go through those withdrawal symptoms. You do what you need to do. You learn new thinking tactics. You learn new skills. You do this, you do that. You work your quote unquote program
mm-hmm,
and you go through it without any assistance
mm-hmm,
other than perhaps a clinical intervention.
mm-hmm.
And that works for some people. And I don't want to discount that at all.
No, not at all. Yeah, it absolutely works for some folks.
And then there's where I need more assistance. Like you
Yeah.
said, I need my brain to just calm down. I need to stop whatever this craving is, or I need to be able to focus or this, and I need some medication to help me do that.
Yeah.
And you're right, it is a judgment because oftentimes those that are abstinent 100% look at the individual who's using the medication and say, if I could do it, you could do it.
Mm-hmm,
There's no reason that you have to do this.
mm-hmm,
I can tell you that I've never been an opioid user.
mm-hmm,
So I don't know what's going on for them. I don't know the extent of their cravings. I don't know the extent of their mental anguish. I don't know the physical. I know it because I've studied it,
mm-hmm.
but I don't know it.
Know it, know
I
it.
don't know how, if I can't settle down my brain, I do because of my methamphetamine
Mm-hmm.
recovery and use. But I don't know what that other individual is either dealing with or working through or in need of. And I'm not a medical doctor.
Yeah.
So would I rather see someone going in and getting their medication for medically assisted treatment, or would I rather see them on the streets getting well using heroin? I'd rather see them going in and getting their medication from a prescriber who knows and is working with them on making their dosage appropriate and is monitoring them.
Mm-hmm. Mm-hmm.
But when there's some people, and I can't say everyone, I particularly am one of those that is abstinent,
Mm-hmm.
but I choose that for me.
Mm-hmm.
That's not to say that if I needed medication for something, I wouldn't go and get it.
Right.
But there are people who will say, oh, you're not clean because you're on MAT. And that comes from a lack of understanding of
Mm-hmm.
what medically assisted treatment is. And it also, when the message for MAT had such a negative connotation years ago, to where now one of the things I strive to do is I make sure that people know it's a medical intervention, because that has a different connotation to it. If I can say, oh yeah, I'm getting some medical assistance with this.
It makes me think of the growing edge that we have seen in Oregon in treatment in general,
Mhm.
around the realization that there isn't just one path for everybody that's going to work for everyone. And that
Exactly.
for some folks, they can come to their appointments on time, not use, take their medications, do everything that they need to do. But that's not everybody. And on us offering to help shouldn't be just for the folks where that will work for them. And I think that's the new realization. And I see that wrapped into this thinking around MAT is that we need different tools in our tool belts for different folks because one size doesn't fit all.
Exactly. And that's another thing that's happening in Oregon, is looking at it at that adolescent population.
Mm-hmm.
I was in a meeting earlier today about adolescents and the residential treatment, and someone made the comment, we need to get past or figure out a way that we're not just giving adolescents a modified version of adult treatment. 20 years ago, when I started in the field, that's basically what it was like. Okay, we're going to give kids basically the same treatment. Even their assessments were the same. Even their assessments were, have you lost a job? Has it affected your relationships? Have you?
Right.
And kids haven't experienced that. But
Right.
yet we're
Nor are their
asking
brains
them,
formed.
we're asking them in assessments about
Right.
these things that they're like, no, man, I live with my parents.
Right.
Do you have difficulty paying your bills? No. And so I'm really glad to see that's happening in Oregon too. Is really the
Good.
focus is really too, and it comes down to that prevention piece of it, and creating that preventative model of kids. Generally, yeah, there's some, but generally they're not late stage addicts yet. They might have gotten an MIP, or they might have gotten this. And there are those outliers that, yeah, these kids have some real problems and we need to be able to help them. But for the most part, they're still in that, this is still fun. And so I think I'm really pleased to see that adolescents and adolescent services are increasing outreaches, peer services for them, and really giving it a different dynamic than what it has been. And I think that's an important piece of this too, is really looking at the fact that the messaging around treatment has changed. It's no longer you're a bad person, or you're a failure, or it's no longer that negative piece to it. I think it was probably about 10 years ago that the messaging around substance use started changing. Treatment around it really started changing. It's a slow process because some of the guidelines are still the same. And so we're using outdated guidelines. We have some providers that are so progressive and willing to just do that outside of the box kind of thing. And I can't wait to see when all of the providers do that, when all of these old guidelines or regulations or thoughts about it are gone. Because once that happens, that means the stigma starts dissipating.
Absolutely. Can you talk, Michelle, about your progressive providers and the outside of the box things that they are doing that's different from how it used to be?
20 years ago, it was basically you couldn't even charge for a clinical intervention without sitting in an office. You had to be in the building, basically. So now with the outreach and the in-reach, and we also have mobile crisis units now. We have one program in Pendleton who just bought a fully equipped medical therapeutic trailer to take around. So we have trailers that are being built like a mobile medical type trailer.
Oh, wow.
We have peer support for people that are in the ED room on a regular basis. And then Measure 110 has changed it drastically. And I know you remember this. One of my first introductions to it was going up to Seattle.
Mm-hmm.
And that was one of the first programs where I saw an LCSW was part of the police that were going out to the camps, and she would ride with, and she would go to the camps and meet their mental health needs. And that's now happening in Oregon.
Such a cool model, and I'm so
Yeah.
glad to see it happening.
Yeah.
Yes.
It's happening at all levels.
Mm-hmm.
So just a little bit of my story is at one point using methamphetamines a lot. I was having a really hard time. Someone thought that I had attempted suicide, and I hadn't at that time. But there was an officer in Central Oregon. He was a lieutenant at the time, and he dropped everything when he heard the call and he heard my name, and he came over to my apartment, and he walked around the block about 3 or 4 blocks with me, just talking to me.
Yeah.
And that was my first experience with an officer who said, hey, somebody cares about you.
Yeah.
And so on my 20th anniversary of my sobriety date, I actually called him and I told him thank you, because he was the one and the only one that, like I started this out with, demonstrated that I was worth it.
Yeah.
And so on my 20th anniversary, I called and I said thank you, because I wouldn't have, and I still remember this, that him doing that. And I remember him telling me, Michelle, I didn't have to do this.
Yeah.
And I think that's where we're getting to with our programs now,
Mm-hmm.
is I don't have to do this. I do this because you matter.
Yes. Yes.
And I think that we're getting it throughout all levels of public service in general. It's a different attitude, because it's become so prevalent that there's very few families that aren't touched by it in some way.
Yeah.
I don't know anyone that I know. Everyone I know is touched by, of course, not only my use, but also my recovery. And I think that there was a time that the stigma and the messaging around it was in such a negative way that families couldn't admit that they were touched by it.
Mm-hmm. Mm-hmm.
And now the messaging, I think, is changing. It's slow, but it's changing for the most part to where it's not your fault. What do you need? How can we
didn't
help
fail
you?
as
What
a family.
happened to you?
Mm-hmm. Mm-hmm.
And you see more of a willingness now to take it out of that of your behaviors make me look bad.
Yeah.
To how can I help you get through whatever this is that's happening for you?
Yeah.
And like I said, I think that started changing. I guess you could say that's one of the good things about when we start focusing in on one thing,
Mm-hmm.
because then that's all the attention goes to it. But at the same time, all the attention goes to it, but it's also bringing it up to the surface.
Mm-hmm.
I want it to be that we're talking about drugs in general.
Mm-hmm.
But if the focus on opiates gets the attention to the issue,
Mm-hmm.
then I'm at least happy with that.
Yeah. Yeah.
But I think that it is changing. It is getting better. People are more inclined to see it for what it really is. I've seen a few obituaries where in the past it was always this, oh, they were such a good person. They were this or that. They were blah, blah, blah. And I've read a couple where it's, they're talking about the fact that my 23-year-old son who passed away overdosed from heroin.
Yeah.
This is real. This is an honest reflection of what addiction did to my son.
Yeah.
I could tell you that he's this and that. And at one point he was, and he had the capability of it. And I think that the more you get that out there, the reality of addiction and substance use, the more chances there are that people are going to be recovering.
It puts a human face on it, makes it relatable. Yeah.
Yeah.
Yeah. The other thing I've noticed over the last 20 years is that we love silos. My goodness, we love silos, right? That there has been a breaking down, at least attempts to start to break down that silo between substance and mental health. where you had to fix one in order to fix the other, which was ridiculous. But then now it's being seen as more integrated with the whole person versus one versus the other. I'm wondering if you have some thoughts on that.
Yeah, I think that bringing that integrated, and not only with mental health, but with the physical health,
Mm-hmm.
because the substance use has such a horrendous effect on the body. I think when we look at it, I like to use the word holistic because it really is all of the pieces of that human being that we need to make sure are okay.
Yeah.
And that means that we work on it simultaneously. We don't say, oh, okay, we're going to fix that broken leg, but you just go ahead and drink all your alcohol, do whatever, use your meth, do that. We're just going to fix your leg and we're just going to worry about your leg right now.
Right.
So bringing that mindset in that, no, we're not only going to fix your leg, at the same time, we're going to start talking about and working through some of these emotional and mental distress that you're experiencing. And then we're also going to talk about some of this substance use you're using
Mm-hmm.
and those risky behaviors.
Mm-hmm.
And you start looking at that person in a three-dimensional way of, we take care of you.
Yes.
We don't just take care of, I'm not a big believer that I can take care of one piece and then the rest is just going to fall into place.
Right.
And having staff available at substance use programs that have that integrated, that have that ability to say, you know what, I'm noticing some of this. I think I need to get you to someone who's really qualified in identifying this and helping you through that.
Yeah.
Let's just see what this is.
Yeah.
And if it isn't anything and it is strictly substance use that is causing this concern, I'm still going to be here walking with you as well.
Absolutely, because going through all of that is stressful and can cause symptoms as you're trying to move through your addiction and the stuff that you're dealing with. Of course, stuff is going to start to come up for you.
Exactly. And there's symptomology of substance use that can mimic mental health issues. When I think of methamphetamine psychosis is one of those things that comes to mind.
Absolutely.
It can mimic borderline personality. It can mimic schizo affect. So there are things that can be mimicked by my drug use.
Or if I'm using it long enough, can cause.
Can lead to.
If you're looking at like
increasing
Korsakoff's.
Can lead to increasing my mental health issues. So being able to now identify that, okay, so there's more going on here than just the methamphetamine because you've been clean and sober now for 6 weeks and I'm still seeing this.
Yeah.
We need to get you some help in this department.
Yeah.
And I think it needs to be clarified too that substance use counselors need to work within their scope of expertise. They need to work under their certification, what they're certified for. If they don't have that mental health component as far as their, what I call alphabet soup, then they should not be attempting to do mental health therapy.
Yes.
However, they do need to be able to make the proper referrals. As a substance use counselor, that's part of the job. Knowing when I need to refer a client to this service. And part of that means there has to be a relationship between the services. It can no longer be, we only do mental health, we only do substance use, and we don't talk.
Right. Yeah.
There has to be that communication. And it also, not only with mental health and substance use, but also with the corrections. And with anyone who is involved with that individual's life. With the medical staff that are seeing them. There needs to be that communication. And everybody has to have the same goal in mind, which is making sure that this member, client, patient is getting the services they need for the ailments they have, whatever that looks like, and do it in a team fashion.
Holistic care.
holistic care.
Yeah.
For the holistic person.
Right?
Yes.
So in our time that we have left, Michelle, I'm wondering if there's anything that we didn't talk about or if you have any last thoughts for our listeners.
What I would like to say for the last couple of minutes is the importance of breaking the stigma associated with substance use. Making sure that when I'm thinking about substance use or an individual who is suffering from the effects of substance use, what lens am I looking at that through? Because if I'm looking at it through a judgmental, degrading, prejudice viewpoint, I'm not going to be able to give that individual what they need.
Yes.
And that's not just in the therapeutic world, that's just in the world in general.
Mm-hmm.
If I'm looking at it as they're the problem, then I'm not looking at it through an empathetic, how can I help you? And it doesn't matter how many years of experience or what. I think the main thing that we can do human to human is look at the lens we're looking through at other humans for the situations they're in.
Mm-hmm. Mm-hmm. Because judgment and damnation doesn't really tend to lead to behavior change.
Exactly. And so I think that's probably the last thing I'd like to say about it, is make sure our lens is clean.
I think that is a fantastic place to end, and I couldn't agree more. So thank you, Michelle, so much for your time. I so enjoy when you and I get to work together and we get to partner on projects. So I'm so glad that you came and joined me today. And please, if there's other topics that you want to come and talk about in the future, please let me know and come join us again.
I will. Thanks, Chris.
Thank you.
The Center Collaborative is a production of the Oregon Center on Behavioral Health and Justice Integration, a specialized division of Greater Oregon Behavioral Health Incorporated. It is produced by me, Chris Thomas, with production assistance from Patrick Kennedy. Music by Patrick Mulvihill and Patrick Kennedy. Subscribe to the Center Perspective using your favorite app. To learn more about criminal justice and behavioral health in Oregon, visit the Center's website at ocbhji.org. You can also find us on Facebook. We'd love to hear from you. Please reach out to us. Join us next time as we chat with the experts about programs and partnerships at work within this complex and yet compelling field.